So should we start? Hello?
Yeah, sure, we can start. Yeah.
You can put your camera on if you want to. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 14J, which is Hematology General and Fundamental. And we are streaming live from Suraksha Diagnostics, Kolkata. A very, very pertinent and very interesting topic, flow cytometry, principles and technique. And today it is session 1, which will be on instrument, dynamics, mechanics, calibration, and the most important, the quality control. To talk on that, we have an expert person who is Dr. Gautam Gopal Bhagwat. He is an MBBS MD from R.D. Gardhi Medical College, Ujjain, a PDF in Laboratory Hematology, Tata Medical Center, Kolkata. He is presently the consultant hematopathologist at the famous Suraksha Diagnostics, Kolkata. Also the section director of hematology, immunohematology, and flow cytometry at Suraksha. Dr. Gautam has been specially trained and has acquired organized and structured hematopathology reporting skills and foundational knowledge to improve patient care. He also had a 1-month hands-on training at the University of Salamanca, Spain, where he gained experience in flow cytometric analysis at various hematological malignancies and MRD analysis. In 2019, he received the Berendhoven Travel Award at the annual conference of the ISLH in Vancouver, Canada. He has completed his MBBS MD from RD Medical College, Ujjain. His areas of interest is hemato-oncology and flow cytometry. So you can understand he is the right person to talk on flow cytometry. So before I ask him to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. Let me request Dr. Bhagwat sir, please start.
त्यांनी लिंक पाठवली आहे ना तुझं काय गौतमचं ते ऍडव्हर्टाइजमेंट.
Hello, Dr. Bhagwat, please start.
Yeah, I'll just share my screen. Yeah, am I audible?
Yeah, perfectly fine. Please start.
Yeah. Good evening, everyone. I hope everybody is safe, and I would like to thank Dr. Nadeem for giving me this opportunity to talk on flow cytometry principles and techniques. Over the next 60 to 70 minutes, I would go through basically what the flow cytometry machine is, what we as doctors and technicians do with it, what is the importance of quality control. And I have kept this talk very basic as it is for the residents and the students per se. So I would not go much into the complicated things of it, and I'll just keep it to a basic. I'm sure everybody knows these two people, great personalities, Anton von Leeuwenhoek and Romanowski. So we look into the microscope, into the slides, do a peripheral blood smear examination, do bone marrow morphology, give our diagnosis because of these two stalwarts who gave us the microscope and the staining, because of which we see the cells, classify them. But today we are going to talk about these two people who gave us something with which we could sort cells. So what does a flow cytometer really does? It sorts cell, it classifies cell. I need not tell you the importance or the contributions given by Wallace H. Coulter, but the other person, Leonard Herzenberg, is one who made the first prototype of a fluorescence activated cell sorter, the FACS, and he actually took a loan from the IBM to set up his entire lab, but he gave an instrument which is an integral part of a hematopathology lab, at least in today's scenario. So I cannot imagine a lab without a flow cytometer, a hematopathology lab, because if you ask any PG student or a new resident, what does a flow cytometer does? It diagnoses leukemia and lymphoma. So a diagnosis of leukemia, lymphoma, which is the core of hematopathology, cannot be possible because of flow cytometers. What is flow cytometry actually? So it is composed of three words: flow, cyto and metry. So flow means fluid, cyto is the cell, and metry is measurement. So flow cytometry measures the properties of cell as they flow in a fluid suspension across an illuminated light path. So are we using flow cytometric techniques in our lab? So for PGs it might be we don't have flow cytometers in our lab, but I'll make this point very clear. The very basic instrument that we are using, a cell counter in which we do our routine CBC, is based on flow cytometry. I'm sure you know what this is. These are normal RBC and WBC histograms which help us in giving out the RBC counts, the MCV or the differential WBC counts. Along with that, we have something called as the scattergrams. Now all these, whether it may be due to impedance or whether it may be due to some physical property of the cell, these are based on the flow cytometry technique. That is a cell in measuring the property of a cell in a fluid. So what different are we going to do with a flow cytometer if our cell counters are giving me the properties of the cell? The cell counters, what they are not doing is they are not incorporating an important property of the cell, that is the antigenic property. So to check the antigenic property, what we do is we do a immunophenotyping. Immunophenotyping, the most common that we have in our labs is the IHC or the immunohistochemistry. I guess there is some disturbance. Yeah, I'm audible? Most likely, yes. So, immunophenotyping in our labs is mostly the CD20, CD3 is one of the basic immunophenotyping that is required in our labs, and this is a IHC photo of a lymph node showing the follicle, which is full of B cells. Now, B cell has a CD20 over it, so a CD20 follicles, the B cells full of follicles. And what is this? These are all the parafollicular areas with the CD3 positive T cells. So this is the immunophenotyping which I guess all of the medical colleges now have, that is the IHC. The other technique for immunophenotyping that we have is something that we rarely see. In fact, I have very rarely seen, hardly one of these slides I have seen in my 20 years that after MBBS, and this is a rare, but this is another technique of immunophenotyping, and most likely this is the glomerular basement membrane stained with some immunofluorescence. And so these two are the techniques for immunophenotyping. But what we are going to talk in next around 40-45 minutes is this, that is the antigenic properties of the single cells in form of the flow cytometry. And this antigenic properties I am going to see on this on the softwares on my computer, and then I would give a diagnosis. Again, flow cytometry is not only diagnosing leukemia and lymphoma, but surely it is the one of the most important applications of flow cytometry. What is the workflow in a flow cytometry lab? We receive the sample. This sample is processed by my technician, preferably in a biosafety cabinet. This processed sample is put into the flow cytometer. The machine gives me something of these kind of graphs on my computer. I analyze these graphs, I play around with the cells, I play around with the graphs, and then give the expression pattern of various antigens, and by my knowledge of various antigens present in various kinds of leukemias and lymphoma, I report out the immunophenotyping test. So this is the normal flow workflow in a flow cytometry laboratory. It has two important components. One is the machine and the human. What does a machine do, or what are the components of the machine? The most important components: fluidics, optics, electronics. These three I will come again and again, because these three are the components of the flow cytometry machine which are important. So as the postgraduate students are also listening to this talk, or they compose of the majority of the audience of this talk, there are certain questions which would come, which you would face in your examinations, maybe in form of full notes or the short note, or when you go out of the PG, when you pass your PG, you will face certain competitive examinations in which there would be multiple choice questions. So understanding next few slides would be very important, because if you are going to appear for any hematopathology, a multiple choice question or competitive examinations, you are bound to get questions from flow cytometry. And next few slides will give an insight on what the machine does and what we do while processing the slides. We're processing the sample. So what we do, we process it, we acquire it, and we analyze it. So three things that the machine does: fluidics, optics, electronics. Three things that a technician or a doctor does: processing, acquisition, and analysis. Now this is the patent that Dr. Coulter had given for his impedance technique, and this is one of the older machines that Herzenberg's lab at Stanford had. These are the early sorters and the analyzer. These are huge, and if you see, these are almost covering an entire room with so many buttons, so many complicated complications in it. and so many complicated wires going over here, so many buttons. There are various areas where you have to work. We are lucky to have compact instruments. These are tabletop instruments and very less complicated. So the life has become easier for us. What actually is happening in this machine? So flow cytometer is composed of three main components. As I told, fluidics, optics, electronics. I will keep on repeating this. So what is fluidics? Fluidics, cells in suspension or bought in single file. What is single file? That is one cell passes at one time. Next is the optics, a focused laser scatters the light at the interrogation point, and either it will scatter the light or emit fluorescence, which we collect. These collected signals in terms of photons are converted to electrons and then converted to digitalized values that are stored in a file for analysis. So as I told, this is the fluidics. The sample goes in and then the cells come out in a single file, one at a time. These are interrogated by a stream of laser. Now this cell is interrogated over here. Now we have something called as obscuration bar. Now why this is important? Because when the cell is not passing through it, when this area is empty, this laser will continually hit this detector. So there is an obscuration bar which is set at a low angle. So any negative light would not go and hit the detector, so we get very less background noise. But when there is a cell at this interrogation point, there would be lots of scatter. Now this cell will scatter light in all possible directions. What we do is we capture this all scatters with various PMTs. Now what is a PMT? It is a photomultiplier tube. Not only would it scatter the light in all the directions, if there is a fluorescence molecule attached on it, it will scatter light of different wavelengths, and accordingly we will capture those or detect those with our photomultiplier tubes. These photomultiplier tubes will convert this, will send these photons into a ADC, that is the analog to digital converter. These analog signals are converted into a digitalized signals and they are sent to a computer or the analysis workstation. So this area is the fluidics, this entire is the optics, and this is the electronics. Now this is the heart of the cell. Now this area is known as the flow cell, where the cells go into a single file. Now how does this happen? This is because of the hydrodynamic focusing. Once the sample is injected into the stream of sheath fluid within the flow chamber, they are forced into the core stream. So the sheath from outside is a pressurized and the sample goes through this under pressure in a single file. And here where the nozzle becomes very less diameter, you have a single cell passing one at a time in a single file. Because of the laminar flow, there is no mixing of this sheath and sample. So ideally, only one cell particle should pass through the laser beam at the given point of time, and this is the purpose of fluidics. Optics consist of lasers. Argon laser is the most commonly used laser, which is a blue light source. There are other lasers also, such as the helium neon laser or a helium neon cadmium or the ultraviolet lasers, but the most commonly used, I'll keep this basic, and the most commonly used laser is a blue laser, which is the argon laser. Next are the filters, mirrors. I'll come to what those are, and last are the detectors. So this is our optics. Now this is the laser beam. Again, these are the cells coming in a single file. This cell scatters the light in all the possible directions. And then we have put these detectors where this scattered light will be detected. So coming on to forward scatter. What is a forward scatter? So when this laser is going in this path, a cell comes in between and scatters the light in the forward direction. Now this cell will also scatter light in all the other directions, but what we are focusing is this scatter that is going in the forward direction, which is detected over on this detector. So what happens? If a small cell passes through, there would be a small scatter. If a medium sized cell crosses, it would have a medium sized scatter, and if a large cell crosses, it would have a large scatter, and accordingly the voltage is generated, and you get a low voltage or low intensity graph over here. If for a medium size, you will get a medium voltage graph, and for a large, you will get a large voltage graph. So now when we see in a peripheral blood smear, what we see is that the neutrophils, the lymphocytes are the smallest cell, neutrophils are more larger than those, and the monocytes are the larger cell. But once the lysis has been, the red cells are lysed, we put in the diluents, this would change, and by volume the neutrophils would be the largest cell, the monocytes would be a medium sized cell, and the lymphocyte still remains the smallest cell. So this is something which I would like to emphasize, that under a peripheral smear, maybe the monocyte is the largest cell, but for a flow cytometer, for our routine cell counters, the neutrophil is the largest cell, then comes the monocyte, and the smallest is the lymphocyte. I'll come to this later. So what exactly happens is, with this scatter, you get something like this. So these are the single parameter histograms. Single parameter histograms where these are the cells with most size and these are the cells with the least size. Isn't it something like this which you see in your routine 3-part cell counters? So these are the neutrophils, the monocyte basophils, eosinophils, and these are the lymphocytes. So this is a single parameter, that is the size that we are taking into consideration, and we have classified the cells as neutrophil, mid-sized cells, and the lymphocytes. Coming on to the second parameter. So this second parameter is the site scatter. So site scatter is based on the cytosol complexity and the granularity of the cell. So as you can see here, the eosinophils have the most large granules inside. Basophils although have this granularity, but they tend to degranulate, and therefore basophils won't have much of a side scatter. Neutrophils have small fine sand-like granules as we describe it, and these would have some scatter because of the complexity of the cytoplasm. Lymphocytes are the most simple cells. They are least complex. There are no granules, and monocytes somewhere in between. So again, the lymphocytes would have the least side scatter, monocyte more than that, and neutrophil more than that. Eosinophil more than neutrophils. So this is our second parameter. So when we compare these two parameters, if I compare the forward scatter on this, remember forward scatter was directly proportional to the size. So what I am going to get is the granulocytes towards the most right, then next to it would be the monocytes, and then next to it would be the lymphocytes. Had we not had this side scatter, all three would have been in this same line. So lymphocytes over here, monocytes over here, and neutrophils over here. But now we have added a second parameter to it, and that is the side scatter. And as I told, the granulocytes have more side scatter, then comes the monocyte, and the least is the lymphocyte. So again we have this. What are these cells? So these are cells which have the least forward scatter and the least side scatter. That is, they are the smallest in size and least complex. Most likely these white cells that my arrow is pointing are the red cell debris, which usually we do not take into consideration. So again, the smallest and the least granular population, monocytes, the largest and the most granular population, the granulocytes. And if we want to do more sorting, then the lower half or the lower 80% are the granulocytes, the upper one are the eosinophils, and here in between somewhere lies the monocytes. So this is what we have got in a peripheral blood, that we have differentiated lymphocytes, monocytes, neutrophils, eosinophils. Do we need something more? Yes, because we have to diagnose something. We have to diagnose leukemias, lymphomas. We have to sort many more cells. Now, how do we do that? So, for example, this is a population of so many people. If I have a single parameter, male, female, boy, girl. So, for example, so I have only only a single parameter in which I can sort this population. I can add one more, presence of a beard, if I want to sort amongst the boys. So I add a parameter of beard. But this might not be suffice, because I can very well see that there are so many different kinds of people in this entire population, or if I say there are so many different kinds of cell in this sample, that only differentiating it into 2 or 3 cells is not sufficient for me. So what I do is I add one more parameter, maybe a color of the skin. I add one more parameter, maybe presence of spectacle or not, so on and so forth. And then I can actually, by adding more and more parameters, what I do is I can actually sort each and every person or cell in this sample. Now, how do I do it? So I had size with forward scatter, complexity or granularity with side scatter. The third thing which I have is the antigens present on the cell, and these are the CD markers that we use. Now, I'm sure everybody of us in our PG times have been mugging up these, but when you get into practice, I can assure you need not mug up. You know it by seeing the cells, what antigen is for what. So practicing this becomes important, and therefore I would like to highlight here or emphasize here is that all the postgraduate students or the residents who are just starting the flow cytometers or analyzing the flow cytometers or getting into it, they must see more and more of reports, they must see more and more of cases, and they must do more and more of analysis. Once that is done, I'm sure you need not mug up these and you will know it automatically. I am not going into the details of the CD markers here because I have 2 more talks most probably in the next month, and there I would be discussing the applications of the flow cytometer in hematology, and there I'll be keeping on repeating these all again and again, and therefore we can discuss it later. But I'm sure certain CD markers are very famous amongst the students and the residents, and that would be a CD3 for T cell, a CD20, CD19 for a B cell, MPO for myeloid, CD45 as the leukocyte common antigen. So these are cells which we all know already, and these are the CD markers which I would take in my examples in this talk forward. So how do I know whether, how do I come to know whether a CD marker is present on a cell or not? For that, what we do is we add a molecule which is known as a fluorochrome to this antibody. So an antibody directed towards the antigen which is bound to a fluorescein molecule known as a fluorochrome is added to the sample. Now, what exactly is the property or what is the fluorescence? So whenever a light strikes a cell or this fluorescein molecule, it gets excited, then it loses some energy and emits a light of another wavelength. Now, how does this happen is, I'll take you back to the electromagnetic spectrum that we read in 11th, 12th most probably in our higher secondary classes. So 2 phenomena that we must know here is, one is the relation of wavelength with energy and frequency with energy. So this is our rainbow: violet, indigo, blue, green, yellow, orange and red, the VIBGYOR. Beyond this is the ultraviolet area, beyond this is the infrared area, and as the wavelength goes on increasing, the frequency goes on decreasing, and so does the energy. So wavelength is inversely proportional to frequency and energy. Now I'll not talk of frequency anymore, I'll talk only about wavelength and the energy. So if I excite a molecule with this wavelength, that is somewhere around 480, which is in the blue spectrum, it will release energy. So release energy, it goes to the right. So it will emit energy in either green or yellow or orange or red. Never would it emit this color. So this is one thing which we need to know, that the emission of energy is always towards the right hand side. So therefore you will always get a graph like this. Here it gets excited at some wavelength, and this is the peak of the excitation known as excitation maxima. Then it will release some energy and emit a wavelength of towards the right hand side, and this is known as the emission maxima. That is the maximum intensity, that is the emission maxima. The difference between absorption maxima and the emission maxima is known as the Stokes shift. Now again, not going into the details of Stokes shift or absorption maxima, emission maxima, but these are helpful when we design the panels for our diagnosis of leukemia, lymphoma, etc. But knowing what is Stokes shift is important, and knowing what is absorption maxima and emission maxima is important. What are different kinds of fluorochromes? So again, I would only emphasize on 2 or 3 which are most common, and that is the FITC or the fluorosin isothiocyanide, phycoerythrin or the PE. PERCP is one more which is commonly used, that is pyridinine chlorophyll protein. If you see, this excites at 488 nanometer, that is our argon laser blue color light, and it would emit at 518 nanometer, that is in the green zone. So absorbs blue light, emits green light. So that is FITC. This absorbs blue light, PE, emits somewhere into the orange red area. Now fluorochrome selection is also very important, and it depends on the number of antigen present on the cell, how we select the fluorochrome. But again, I'll come to selection of fluorochrome when I'll discuss panel designing in my next talks. So today I'll move forward. Now these are our 4 FITC, PE, APC and PERCP. Now forward scatter, as the size was growing, scatter was growing. Side scatter, as the complexity was growing, scatter was growing. What happens over here? As the number of antigens increases on the cell, the intensity increases. So a cell with less antigen or no antigen will have a dim signal. A cell with moderate number of antigens will have a moderate signal, and a cell with most number of antigens would have a bright signal. So something similar to what we saw during the forward scatter: a small cell, a medium sized cell and a large sized cell. Here what it is: a cell with no antigens, a cell with moderate number of antigens, a cell with the maximum number of antigens. So similarly, a histogram would be plotted. So a brighter fluorescence would mean more number of antigens would be on the right hand side of this plot, and these are the cells with no antigen or less number of antigens plotted on the left hand side. If we see it into 2 plot, that is PE on one and FITC on the other. So remember, last 2 into 2 plot was a forward scatter and a side scatter. Now here we have two fluorochromes emitting light, FITC green and PE orange red. So if we see these green cells, these are cells which are positive for FITC. That is, any antibody that I bind to FITC, the antibody bound to FITC was in the antigen was more number in these cells. These cells have the antigen for the antibody bound to PE. And what are these cells? These are double positive cells. That means these cells have both the antigens on their cell surfaces which the fluorochrome PE was bound or the FITC was bound. I'll clarify this in my further slides. But before going to that, we will just see how actually the optics work. So for that, we have three kinds of different filters. Either it may be a filter or it may be a mirror. The difference being, filters would let the light pass and absorb rest of this. The mirrors would reflect and let the light pass. So not much of difference. The important thing that I would like to emphasize is that there are three kinds, that is long pass, short pass and band pass. Long pass, for example, this is LP500. So long pass means it will allow all the wavelengths more than 500 to pass through, rest would not get passed through. A short pass, for example, SP500, all the wavelengths less than 500 nanometers will pass through, rest will not pass. A band pass means a specific band. So if I say 550, so a range of 50 nanometers, that is 475 to 525. So these band pass filters will allow only 475 to 525 to pass through, rest will get absorbed over here. Similarly, there are these dichroic mirrors which are usually placed at a 45 degree, and these have the same concept. Either this can be long pass or short pass or band pass, but what they do is they reflect the light and allow the remaining light to go through. So this is again the model which I had first shown you. Now I will try to explain this with the fluidics and the optics. So this is a laser, 488 nanometer blue argon laser. Going through this is our obscuration bar so that the negative signals are not going and hitting this PMTs. PMTs again I'll tell are the photo multiplier tubes which amplifies the photons that are hitting the this detector. So basically these are the detectors. Now what happens is there is a cell in this interrogation pathway. According to the size, there would be some forward scatter, rest would be scattered in all the other direction. We are interested in this perpendicular scatter. Here we have a mirror 500 nanometer long pass. So it will allow all the wavelengths of more than 500 to pass through, rest all would get reflected over here, and we will get this signal coming to this PMT. Now what are these less than 500 nanometers? So those are basically the blue light coming through side scatter. So what this PMT is detecting is the side scatter. Now this cell has all the whatever antigens are present with the fluorochrome bound, it will emit some kind of light, and as I said, it would be towards the right hand side. So this will emit light definitely more than 488 nanometer. So all those more than 500 will go over here. Here we have another mirror 640 nanometer short pass. Now what is a short pass? Short pass means it will allow all those bit less than 640. So 500 to 640 will pass through, other will get reflected and go over here, and here we can detect the far red signal. From this 500 to 640 there is another mirror 560 nanometer short pass. All those cells, all those photons wavelength 500 to 560 will pass through, rest will get reflected over here, and we will get some orange red signal over in this PMT. Rest all the light going through is the green light, which we can see on this FITC signal. So this is the basic model of how optics works in the flow cytometer. Now I have already told how voltage or plot is generated. So this cell, when it is out of this interrogation point, nothing is going through, we have a flat line. As soon as it enters over here, it will start giving out some photons or some scatter, and when it is in the middle, it gives the maximum intensity, and then when it again passes through, then the graph falls down. So what does this imply? So this is the time. So it started from here and it went towards here. What is this? This is the maximum intensity of the photon striking the detector. The area under the curve can also give you the same thing. So the width gives you the time and the height gives you the intensity, or the area gives you the intensity from the PMTs. Now from optics we go to electronics, and in electronics this PMT, in the older instrument it was all analog amplification, and analog amplification would then get digitalized and come to the computer. In the newer instruments, the digitalization takes place earlier. Why has this change been done? Because nowadays instead of 8-bit or 10-bit, we have more bytes. So 2 to the power 10 would give a less resolution than a 2 to the power 32. So therefore the digitalization takes place in this ADCs at the very starting from the PMTs, and then this digital processing goes to my computer. Not much to get into, but this is the change which has brought about better resolution of the events. Now all this goes into a list mode data, and this is plotted onto the graph. So basically sample goes in, we label it with an antibody attached to a fluorescent markers. This gets activated, emits light, filtered and detected by PMTs. This goes on to give analog fluorescent signals which are converted to digital signals, and it comes to the computer. So again, fluidics, optics, electronics, the most important part is the flow cell, where you get the hydrodynamic focusing. Why is it important? Because we want to interrogate one cell at a time. Once that happens, there is scatter in forward direction, in sideways direction, there is emission of fluorescence. All this comes and the data comes to the I'm extremely sorry for this. So all this comes and get into the detector, and this comes to my computer. But there has to be a man behind the machine. Machine is not going to do everything for you, and the doctors, the technicians are the man behind the machine. What we do is we process the sample and put it into the machine. Now this processing which I am going to talk is for the hematology lab only. There are many other techniques of processing. I will not get into the details because I would be focusing on the hematological aspects of flow cytometry. So the techniques that we use is stain, lyse, wash, or the bulk lyse, stain, wash, or the stain, lyse and no wash. Now what is the stain? So stain is adding antibody to the sample, or adding the fluorochrome to the sample. So if we are going to have for example a kappa lambda chain, if you are going to put antibodies, again that it is advisable to do a previous wash and to get better results. This again I will cover in my next talks, in which I actually talk about the application part of the flow cytometer. But what samples are we going to get? So in a routine hematopathology lab, routinely you get the peripheral blood and the bone marrow. Apart from this, the samples in which we can detect tumor cells are the cerebrospinal fluid, the various serous effusions such as the pleural fluid, the pericardial fluid or the ascitic fluid, the vitreous fluid or the intraocular fluid, So ALL rarely tends to go and metastasize into the intraocular area, and so we get samples from the intraocular area. So then the bronchoalveolar lavage, FNACs, or the tissue biopsies. Now the important point to note here is that the tissue biopsies are solid, and therefore before processing it, before putting it into any kind of process, you need to make it into a suspension or a fluid, because flow cytometry measures cells in a fluid. So therefore tissue biopsies are teased, and then they are brought into a fluid state, and then we analyze into a flow cytometer. What exactly in processing is stain? So for example, I want to sort a T cell from the lymphocytes, and further I want to sort the cytotoxic T cell, which has the CD8, and the helper T cell, which has the CD4. So my antigens of interest would be CD3 also. So I'll start with CD45. Why CD45? It is a leukocyte common antigen. So with CD45 I can get the lymphocytes. From that I would try to get the CD3 sorted out. CD3 are the T cells, and from those CD3 T cells I'll try to sort out CD4 and CD8. So for this, what I need to do is I want to first put the fluorochromes. Now I decide a panel, and I link this anti-CD3 with FITC, this anti-CD8 with PE, anti-CD45 with PERCP, anti-CD4 with APC. Then the technicians put all these stains into the sample. These fluorochromes and the anti-CD3 or anti-CD45, CD8, CD4 all gets bound to this antigen. So this is my staining step. I incubate it for 15 minutes in dark. So everything is going to happen in dark. Why in dark? Because these are fluorescent molecules. So if I do it in light, they might get excited, and then they would emit some energy, lose some energy and emit the light. So that I don't want before it goes into a flow cytometer. So therefore most of the process we do it in the dark. Next come the lysis and the wash. So now for lysis, again there are two modes. One is the tube lysis, that is I do the lysis in individual tubes, or I can do a bulk lysis, that is I take the entire sample and I lyse it first, and then I put the remaining pellet into the different tubes. So there are two methods, as I have earlier told, that is stain, lyse and wash, or bulk lysis, stain and wash. Now it depends on what exactly are we analyzing. It depends from lab to lab which methods are better, and there is a good paper on this lysing methods from ICCS, and it has given this tabulated forms of pros and cons for both. It also tells most of the things about lysing, but what we need to know here is tube lysis would give us the best signal discrimination and better separation of populations. But as there are different tubes, differently lysis is happening, so there would be an inconsistency in the percentage of cells in various tubes. Also, there would be increased cell loss and more debris. In bulk lysis, what we do is we take the entire sample and we lyse it, so we get lots of WBC pellet in the bottom, and this we can use in multiple tubes. So for example, I have done 4 tubes, analyzing 4 into 4 16 parameters I have analyzed, and then I feel I want to do more 4, then I can take that pellet as well. So there is leftover suspension for add-ons also, and as the entire bulk is lysed, I can use this for more number of events or large number of events, which is usually done in the when we have to detect some rare events, but it uses more reagents, therefore is more costly. And there are certain studies which says that it alters the lymphocyte subsets, also activates monocytes. So it is entirely the choice of the lab which methods would they prefer, tube lysis or bulk lysis, or for what kind of analysis, what kind of technique they have to use, but those should be protocol based, should be standardized in the lab. Washing is nothing but the excess antibodies that we have put should not interfere with the fluorescence activity and should not give us false positive results. So therefore, we must do the washing. The care that must be taken during that is there should be minimum cell loss and maximum removal of free antibodies. Now, once I have processed this, I put this into the machine. Now, when I put into the machine, there are 2 or 3 things which I need to take care during the acquisition. Acquisition is what? The sample is going through the flow cell, the laser is hitting the cells, and the graphs are being generated. So, during that time, I need to take care. One is of flow rate. If my flow rate is very high, then there are chances that 2 or 3 cells would go together. If my flow rate is very low and if I am going to count lots and lots of events or more number of events, it will take lot of time. So therefore, I need to judge the flow rate accordingly. So initially it might be a low flow rate, but if I see that the resolution is getting good, I would go with a moderate to higher flow rate. The second important thing is to put a discriminator. So for example, when I showed you the forward scatter to side scatter graph, I had shown certain cells over here which were the cellular debris. So I need to set a discriminator. So for example, I set a discriminator before these cells. All these cells would be included in my events, which I don't want. These are debris. I don't want it in my analysis. If I put a discriminator more towards the right, then maybe my lymphocytes would get deleted from my analysis. So therefore, it is important to put a threshold at the proper point, and then you get the correct number of cells to analyze. Third is you can always have a pre-prepared templates, and the cells these templates helps us in sorting of the cells. Then comes the analysis. So once you have got all the graphs, this is one of the most important parts, and here lies in all the skill of a hematopathologist, if I should say so. But one thing which we must remember is, before analyzing, we must know the counts of the sample, and also, if possible, we should have a PBS, or if a bone marrow sample is there, a bone marrow morphology examination with us. Preferably, the person who is analyzing should himself look into the slides. If not possible, then at least he must have a morphology report with him, because it is an integrated diagnosis of morphology with flow cytometry, and without morphology it becomes very tough to analyze in many cases. Now I will quickly run through how we do it, because this is what I will be focusing in my next talk. So here, first we do a side scatter, forward scatter, and so we get all what we have, the singlet discrimination, we do it along the time. Now next is the forward scatter and side scatter. As I had earlier told, these are the lymphocytes, the monocytes, and the polymorphonuclear cells or the granulocytes. If I take the same example forward, I want to differentiate my CD3 with CD4 and 8. Not only that, now I have put 2 more antibodies or 3 more antibodies in this. Those are CD56, CD19, CD14 and CD16. So what I do is, I gate from here. So this is a CD3 side scatter plot. As I have told, brighter CD3 would be on the right hand side, dimmer CD3 would be on the left hand side. Brighter CD3, that means they have more number of CD3 antigen present. Dimmer means they have less number or absent CD3. So brighter CD3 are the T cells, the dimmer are the non-T cells. So from here I gate this CD. What do you mean by gate? So now in the next plot I will take only this CD3. I am not going to analyze these non-T cells. From these T cells I put a CD4:8 and I get all these cells. Those are only positive for CD4. These cells which are only positive for CD8. Few events over here which are positive for both CD4 and 8. So this is a CD4 positive T cell, this is a CD8 positive T cell. What else do I have? I have a CD56. So these are the CD56 positive T cells which we call as NK T cells. Now what are these non-T cells? These are lymphocytes. So non-T cell lymphocyte means they are the B cells, and so I get this CD19 positive B cells. Along with this, if I analyze this monocyte gate with these, then if putting 1416, I can get the monocytes also. So this was just an example of how we proceed with our analysis, which I'll again, as I've always been saying, that in my next talks, that would be my more emphasizing point, and I would try to make more clear about things in that talk. So single parameter analysis, a histogram, I have already told. A two parameter analysis can be a dot plot, which is the most commonly used plots. It can be a contour plot. So these are the cell lines, and the most dense being in the center. Again, a color density plot. So depending on the intensity, you get more dense plots. But the most commonly used plots are the dot plots, or the contour plots. So in short, what are we analyzing? We are analyzing the physical properties. Forward scatter is size, side scatter is granularity. Then we are analyzing the antigenic properties. So this antigenic, I missed out to first emphasize on this, that these antigens are not only present on the surface, but they may also be present in the cytoplasm and the nucleus. And for this, during processing, we add in one more step, and that is to put this antibody inside, we create certain gaps in the membrane by using saponin mostly, and that would help the fluorochromes or the antibodies to get inside the cell and stain the cytoplasmic antigens and the nuclear antigens. So we have the physical properties, the antigenic properties, and on basis of that we characterize the cell. So this is a mixture of cells. These are all labeled with CD3, CD8, CD4 molecules based on the side scatters, on the forward scatter, and the CD348. We have differentiated between CD4, CD8 cells. So this is how the entire analysis takes place. This is a normal bone marrow, the beautiful picture showing almost all kinds of cells that we can have in a normal marrow. The NRBCs, the CD34 B cell precursors, the CD34 positive B cell precursors, the mature lymphocyte, the monocytes, the monocytic dendritic cells, the plasmacytic dendritic cells, the mature neutrophils, the immature granulocytes or the myelocytes, metamyelocytes, monocytes, and the eosinophils. Now, this is something which is very important, that we analyze normal bone marrows, normal peripheral blood smear. Only then we would be able to see what is abnormal. So therefore, the pathology residents who are lucky enough to have flow cytometers in their institutes, I would urge them to see as many as normal peripheral bloods, as many as normal bone marrows into a flow cytometer. Now, normal bone marrows means you would get regenerating bone marrows, or the marrows from the lymphoma patients coming for staging purpose. You can always run those on the flow cytometer and see what different kinds of cells you are getting. Try to analyze those based on the various markers that you can put in. Coming to the last part of my talk, that is the quality control in flow cytometer. So there are three phases, as we all know: the pre-analytical phase, analytical, and the post-analytical. So potential pre-analytical errors are cellularity. So for example, FNA or a CSF or a hypoplastic bone marrow will give you very less cells, and in these less cellularity samples, it becomes very difficult to make much of any analysis. Then plasma cells are fragile cells which would degenerate very quickly. There can be a necrosis, you can have plasma cell loss, you can have autolysis or age. So therefore we prefer to process the sample as soon as possible, or there can be an antigen loss because of again time or the fixation issues. During analysis, we have certain methods to see whether really we are doing proper analysis or not. So first is the internal quality control, the Leving-Jennings graph, which are standard in all the instruments that we use. Similarly, we can do it with the with our flow cytometers also. The next 3 or 4 I'll discuss a bit in detail. So one is the autofluorescence control. What is this autofluorescence? So as I said, that a blue light comes, strikes the cells. If there is a fluorescent molecule over it, it emits a green light. But when this blue light comes, the innate property of the cell might be to emit some light, and that can cause a background fluorescence. So therefore, you always must know what is the background fluorescence of a cell in a particular channel, and therefore we always run a blank tube which acts like a negative control. Next is the isotype controls, which are no longer recommended. Fluorescence -1 should be done for all the fluorochromes. What is fluorescence -1? So for example, I had shown that FITC is CD3, the other three had CD4, 8 and 45. What I do is, I do not put CD3, I put only CD45, CD8 and CD4, and then try to see how much fluorescence is coming from FITC into all these three channels, and so on and so forth. So therefore I can know how much of fluorescence is coming from the other channels. Then you have to check for the viability. So viability, you have PI or the 7-AAD dyes. These go and bind to the DNA, and then the fluorescence, and you can get certain signals. But these are dyes, in these dye would enter only a dead cell. So all those which are negative are actually the viable cells. All those which are positive are actually the dead cells. So you have to analyze on the cells which are viable, that are negative cells. Next is the antibody titration, which is very, very important. So the manufacturer would say that you have to use a 10 microliter of antibody, but then it is important for every lab to titrate it. So serial dilution 10, 5, 2.5, 1.25 microliters. See what is the optimal concentration that saturates all the available sites, thereby avoiding the presence of false positive due to excess monoclonal antibodies into the sample. Then background noise, I have talked of much, and the best control which I feel during analysis is a normal cell from the sample. So for example, a monocyte has a CD4 antigen. So if I want to check whether my CD4 has worked or not, I should look for the monocytes having CD4 positivity. A neutrophil has a CD10 antigen. So if I want to check whether my CD10 has worked or not, I must look whether CD10 is positive in neutrophils or not. So for me, the best is the positive control, but you always don't have a positive control, and therefore you must know what is the negative cutoff and what is the positive which you have to say. Then there are post-analytical quality controls. So there is interpretation of analysis, which is very important. Your diagnosis, your follow-up, you should correlate it clinically, you should correlate it with your morphology. In this way you can have a correlation telling you that yes, your analysis is correct. You have to check that there are no clerical errors during typing of report, and a lab must always participate in an inter-laboratory comparison or a EQUAS. What is the current scenario in flow cytometry? So you may be remembering these Nokia phones which we had around 10-12 years ago. We have progressed to better phones. Why? Because we wanted higher resolution. And same is the scenario with our flow cytometers. It has benefited from the technological developments of monoclonal antibodies, the fluorochromes. The computers are like PlayStations nowadays, and as I told, only an argon laser is not suffice. You have more number of lasers. More number of lasers means you can have more number of parameters. So instead of only 4 parameters, I can go on to 6 to 8. The latest you have 32 parameters with 5 lasers. So this is something which with advancement, the current scenario of flow cytometry, you can get more and more numbers of parameters, giving you opportunity to sort more and more number of cells. Also, what has happened is that artificial intelligence has taken over. Now processing can be done in an automated way. You can load the sample in an automated way. You can analyze the sample in an automated way. I'll present an example after 2-3 slides. But one thing is multi-parameter information at single cell levels. You are now able to detect rare events, and therefore the follow-up of the leukemia, for example, the measurable residual disease has become possible, and you can rapidly analyze large number of cells. But with these advances comes some challenges, and there is a compensation issue. Again, I will not go into the details of compensation. I'll just say that, for example, this is a FITC and this is a PE channel. You can see that there is a spectral overlap. So my FITC is going to go and hit in the PE channel also. So I am going to get FITC signal not only from the FITC detector but also from the PE detector. But I don't want it from the PE detector, so I do some mathematical calculations and I remove this. So these signals are coming into the PE detector, which I don't want, and therefore I do some mathematical calculation. I calculate the percentage spillover, I put my negative threshold, or I change this intensity according to the mean fluorescence, and I get the correct picture. So this FITC, this was not a double positive population, it was only a single FITC positive population, because of certain FITC cells going, certain FITC wavelength going and hitting the PE channel, I was getting these signals over here, which now come down and I get the actual signals. See, this compensation is a bit complicated, and this would take an entire half an hour to 45 minutes to actually understand and to go through. I might not have been able to make you understand it because it is not easy in 1 or 2 slides. But yes, compensation is something which you need to correct before analyzing. The advantages now that we have is that the compensation matrices are already present in the latest flow cytometer software analyzers, and we need not do much regarding these. So when I had an opportunity to go to Spain to this University of Salamanca, where I gained a lot and I learned a lot. So this is one of the cases. Now this is a plot in which there is no gating, or we have not yet classified the cells. Why I put this here is, with this software what you can do is, I click on this button, then I click on this button for automated gating and identification. I just click over here, I check everything is correct or not, I go to OK, wait for 10 to 15 seconds, and what do I get is, everything is gated, classified by the software. Not only that, it has given me the number of events for lymphocytes, for B cells, T cells, CD34, myeloid precursor, monocyte, neutrophils, everything has been classified with number of events. Moreover, it generates a reports and gives me. So this is something which is latest advancement with artificial intelligence, but understanding basics was important before reaching over here, and therefore I hope I could put in some insights on the basics of the flow cytometry, the dynamics of the machine, and the quality control part of it. Next 2 talks I would be emphasizing on the application. That would be more interesting, I can assure you. This was kind of, I won't say boring, but more of a theoretical aspect, but was important to know. So these are the various applications. Yes, the most important is diagnosis and subtyping of lymphoproliferative disorders and leukemias, but then there are so many other applications of flow cytometer, not only in hematopathology, in other areas also, which we'll be discussing in the next 2 talks. To conclude, what I would like to say is, it is not only about the machine and the man. You have to be alert at each and every step. You have to check the sample integrity. Your machine should be working fine with all the quality controls in place. You must have the best softwares available. You must have a standard operating procedure for each and every step. Panels must be designed in an optimal way to give the best from the least. You must participate in some ILC or external quality assurance program, and of course you must have skilled technicians and skilled doctors to give out the best reports and help the most in the patient care. So this is Tata Medical Center, where I gained my entire hematopathology experience in the past 2 years. Then during that I had an opportunity to go to University of Salamanca, Spain, where I learned actual hands-on experience, actually analyzing things and getting more insights into leukemias, lymphomas, the MRDs, the lymphocyte subsets. And this is Suraksha Diagnostic Center, where I am working at present. I have developed the flow cytometry over here in the past 6 to 8 months, and we are ready to go with more and more samples coming in. Thank you very much. This is my mail address if at all anybody has to post any questions. Thank you very much.
Thank you so much, Dr. Gautam Bhagwat. Excellent presentation. You went at a very nice pace and you explained the basic mechanics as well as the dynamics of this complicated machine flow cytometry, which started as a very simple, very single line process. Way back in 1992, I did my thesis on flow cytometry. And now you can imagine about 30 years down the line, the entire instrument, its look has changed. And it's now a very complex instrument, but the basics still remains there. And really one needs to understand every bit of it, the way it works, the way it operates, the way it needs to be managed, and the quality part of it. And of course the compensation part. Nowadays we have software which manages the compensation on its own. So you don't need to do any compensation externally. And as it's developing, and as the amount of money you put in, the better quality flow cytometer you bring in, the more better the artificial intelligence software you put in, the input from the human aspect is becoming less and less. But end of the day, it is not the printout which matters. It is the analytical mind of the man who has to sit down and look at it and decide whether to accept it or not to accept it, or how much to give importance to that. An extraordinary presentation, I would say. Very nicely done. Thank you so much. Just hold on, let me see if there are any questions on the YouTube. Everybody will be waiting for the application part, because that is the one which is more exciting.
Yes.
These are the ones, which nobody wants to know, but these are the important things, because if you don't know the basics, then you'll be caught up somewhere.
In fact, when you analyze the samples in day-to-day life, you come to understand the importance of all this. Maybe when we start our hematopathology career, we are least interested in all these things, and we only go to analysis, how to diagnose, how to do that. But once you get experience, this becomes important, because it affects your analysis. If you don't know what is compensation, you might wrongly label something as positive, although it is just because of the compensation that it has gone into the positive area of it. So these are things which are very, very important. Processing the samples, as the PG students and the residents are listening to this talk, I would urge them to actually process the samples, because you get to know a lot of things once you process it with your hands, once you analyze it yourself, play with the graphs, understand it.
Absolutely right. Absolutely right. I mean, if you do not understand the ABC of the instrument, you will be caught.
Yes.
You really need to understand the ABC, the basics, how it works, what is the way how to function, where are the limitations. After all, there are a lot of limitations in every aspect, and that we have to understand. There are no questions on the YouTube, Dr. Gautam Bhagwat. Excellent presentation.
Thank you very much.
We would love to have you back with the application session 2 and the application session 3. That would be much more interesting, because that is exactly where everybody is trying to put their money in.
Yeah.
Thank you so much.
Thanks.
Right. Please share the PDF of this talk. So that we can upload it on the Google Drive which we have. Thank you so much. God bless you. Good night. Take care. Bye-bye.
Bye. Bye. Bye.
Bye.